All right, we'll wait 2 more minutes before we start. So I'm starting at 1:05. 2 minutes. All right, it's 1:06. I guess we'll begin. As Miss Marsden probably mentioned to you, she has asked me to finish up respiration so that she can start digestive system next time you see her. So that's what we'll be doing today. Respiration. I have, however, posted the tutorial for respiration already, for respiratory anatomy. As of next week, I believe we'll be going back to normal tutorials, which means I need you to make sure you have completed your tutorials on time. Remember, if they're late, you will be losing marks. All right?
Sir?
Go ahead.
Sir, when I tried to do the tutorial, it wouldn't let me access it. Like it said it previously accepted submissions or something like that.
Which tutorial?
The respiratory one, the last one.
The previously accepted submissions.
Sir, it had like a July date or something like that. I don't quite remember exactly.
All right, as you're speaking, I'm checking it. It's Friday, October 9. That's weird. Let me check something else. Mine says Friday, October 9. Ah, yes, I see what the problem is. All right, I'm fixing it as we speak. All right, that should do it. You should be able to post now. And of course, I think you have unlimited attempts, so just keep doing it until you feel satisfied with it. All right, that said, let us do today's lecture. Remember, I'm finishing up respiration. Let me share my screen. Alrighty. I'll be posting this lecture later in the day as well, so you can always review. Because I realize you don't have some of these slides or any of these slides. That said, I'll post the slides in the tutorial section later today, so you can have a chance to review them as well, right? But follow with me though. Ventilation. Ventilation, of course, refers to the movement of air into the lungs till it gets to the respiratory surface, right? So breathing equals pulmonary ventilation, and pulmonary ventilation, of course, is related to the lungs. So ventilation has two basic phases. So far, everything I've said should sound familiar to you, right? We have the inspiratory phase where you take air from the outside and you move it into the lungs. And the expiratory phase, of course, where you move the air from the lungs into the atmosphere, right? Now, as it says here, mechanical forces cause the movement of air. You already know this. You know the reason why air moves into the lungs and out of the lungs has to do with changes in air pressure, right? So for example, well, let me state this first clearly. Air moves from an area of higher air pressure and always goes to an area of lower air pressure, okay? Air does not go from low pressure to higher pressure, always goes from high to low, right? So if you want air to move into the lungs, you're going to have to make the lungs an area of lower pressure, right? And to do this, the diaphragm and intercostal muscles have to contract. External intercostal muscles, right? So the diaphragm has to contract and come down. External intercostal muscles have to contract, expanding the chest. So what we're doing here is that we're expanding the space inside the chest cavity by pulling the diaphragm down and by expanding the ribs. All of this increases the space inside the chest. When you increase the space inside the chest, you drop the air pressure in the chest. And that causes air from the outside to rush into the lungs, right? This should all sound familiar to you already, right? So when the diaphragm contracts and the external intercostal muscle contracts, it expands the space or volume, if you want to call it that, of the chest cavity. That drops the pressure in the chest and causes air to rush into the lungs. All right. Is there any part of that that anybody is not certain of or you haven't heard before? Awesome. So in order for you to breathe out or expire, right, what you have to do is, of course, generate an area of higher pressure inside the chest cavity in comparison to the outside. So when you're expiring, what happens is that your external intercostal muscles relax and they press back down to the original position. The diaphragm relaxes and presses up back to its original position. Now, since they have moved back to the original position, it means that the volume in the chest cavity decreases, right? But remember, there's extra air inside the lungs now because of inspiration. So the volume decreases, but the amount of air inside in the chest cavity is larger than it was before. So the lower volume plus extra air causes a pressure increase. So the lungs now represent an area of high pressure, and the outside is now an area of low pressure. So air gets squeezed out of the lungs and goes back outside. Remember the bottom line. If I want to move air from one place to the next, I have to make the place I want air to go to low pressure. And the area where I want the air to flow to has to be low pressure. So if I want it to come into my body, I increase the volume in my chest cavity, which drops the pressure, air flows into the lungs. If I want air to leave my body, I decrease the volume of my chest cavity, which increases the pressure, air flows out, right? Really basic idea. Now, there are two types of breathing that you can do, right? The first one is called quiet breathing. In quiet breathing, you are moving air into the lungs under the effect of the external intercostals and the diaphragm muscles only. Those two muscles are contracting to pull air in. Remember why? Because they increase the volume in the chest cavity, that drops the pressure, air flows in. In quiet breathing, you're only using those two muscles. External intercostal muscle, diaphragm, right? Diagram here even shows it to you, right? When you want to move air out during quiet breathing, all your body does is it relaxes those two muscles, and then the chest goes back to its normal volume that pushes the air out. So that is quiet breathing, okay? Now, quiet breathing is controlled by something called the DRG, the dorsal respiratory group. And the DRG is in the medulla oblongata of the brain. And you guys should know where the medulla is by now, right? As towards the hind brain, the pons is above it. So the DRG, the dorsal respiratory group, in the medulla controls quiet breathing. Here's what it does. The DRG, when it's active, it sends a signal to the diaphragm, to the external intercostal muscle, which of course we call inspiratory muscles, right? And causes the muscles to contract, which causes air to rush in. So that is inspiration. The DRG sends a signal to the muscles to tell them to contract, causing inspiration. When the DRG deactivates, the signal going to the muscles turns off, and the muscles naturally relax, which of course causes quiet breathing to force air out of the lungs because the muscles return to their original position. So in quiet breathing, the DRG, dorsal respiratory group, sends an impulse to the muscles, the diaphragm, external intercostal, causing them to contract, moving air in. When it's time for you to send the air out, the DRG stops sending the signal, which causes the muscles to relax, pushing air out, right? Now, that is quiet breathing, okay? That is breathing as you're sitting here relaxing, not doing anything much. The other type of breathing we can talk about now is forced breathing. During forced breathing, you're not just using two muscles, right? In forced breathing, you have a multiplicity of muscles involved to move that air into your lungs and out of your lungs, okay? During forced breathing, you have to have additional muscles of course, we still include the diaphragm and external intercostal muscles, right? But during forced breathing, these muscles here contract as well to help increase the volume in the chest cavity, which increases the depth of your breath. So scalenes, sternocleidomastoid, pectoralis minor, quadratus lumborum, erector spinae muscles. When these muscles contract, they allow you to breathe in deeply. So this is not quiet breathing anymore. Remember, quiet breathing is only external intercostal muscles, diaphragm, right? Forced breathing is those plus scalenes, sternocleidomastoid, pectoralis minor, quadratus lumborum, erector spinae muscles, right? And we refer to these muscles here as accessory muscles of ventilation, right? They help you to breathe in deeply. And remember, this is doing forced breathing. But what triggers these muscles during forced breathing? That's what I'm going to talk to you about next. The trigger for forced breathing comes from this structure here in the same medulla oblongata called the VRG, ventral respiratory group. So we have the DRG, and then beside it you have the VRG. When you need to breathe in deeply, the DRG, which sends a signal, of course, remember, to diaphragm and external intercostal muscle, the DRG is also going to send a signal to the VRG, ventral respiratory group, and it will cause the scalenes and the sternocleidomastoid and the quadratus lumborum and etc. to contract, to pull in more air. So the DRG activates the VRG, and they cause all the muscles of inspiration to contract at the same time, pulling air in with force, forceful breathing, right? Now, with in forced breathing, exhalation is not a passive process. Muscles don't just relax. So obviously, you're going to have the relaxation of the inspiratory muscles, right? So all of the muscles here, plus the diaphragm, plus external intercostal, all of them are going to relax when it comes to expiration, forced breathing. But in addition to these muscles relaxing, you're also going to have the VRG activating certain other muscles, which help to force air out of the lungs. And these will include the internal intercostal muscles, latissimus dorsi muscles, and your intra-abdominal, well, your abdominal muscles as well, all right? So here's what happens. The internal intercostal muscles pull the rib cage in. So they have to forcefully pull the rib cage in, decreasing the space inside the chest cavity, right? Latissimus dorsi is a back muscle, and it helps to pull the rib cage as well in, helping to squeeze the air out. Your abdominal muscles contract. When they contract, they push the increased pressure in the abdomen, which pushes up on the diaphragm, which you have to push the diaphragm back up. So these three muscles are going to combine to squeeze down on the chest cavity to help push air out. Remember, they're only active during forced breathing. All right? Only particularly forced expiration. So these muscles, you have the abdominal muscle, rectus abdominis, the intercostals internal, latissimus dorsi, they're all squeezing down on the chest cavity, pushing air out of the lungs. So when you're breathing out during forced breathing, it's not a passive process. Remember, yes, the inspiratory muscles will relax, right? But these expiratory muscles here contract as well to speed up the rate at which you get air out, which means, of course, you can, during forced breathing, you can breathe more quickly in and more quickly out because the muscles are working in tandem with each other, right? All right. So that's the DRG and the VRG. Hopefully that is explained. Before I move on to the next step, are there any questions you'd like to ask? Anything you're not understanding? Now's the time to talk, right? All right, never forget, there's no such thing as a stupid question the first time. All right, cool. I guess everybody's on the same page. Wonderful. I want to talk about a condition that happens sometimes. It happens to a lot of people, particularly people who like to ride bikes and climb trees and things like and get into fights. That is a pneumothorax or a collapsed lung. Essentially, in the pneumothorax, what happens is that air is going to move in between the visceral pleura and the parietal pleura of the lung. Before I move on, do you guys remember what the visceral pleura and the parietal pleura of the lung are? Is there anybody who's not sure about it? Alrighty. Now, this is, of course, an x-ray of somebody's lungs, right? What I'm showing you, these two lines here, the yellow one here, change the color of that, is going to represent the parietal pleura. All right. So that there is the parietal pleura. And the red one here is going to represent the visceral pleura. All right. So I have parietal pleura on the outside, visceral pleura on the inside, okay? Over here, so this lung here, this is showing you, as it says, the lung margin. The visceral pleura is sitting on the lung margin, so this is, so right here. In the pneumothorax, what happens is that a hole develops either in the visceral pleura or the parietal pleura, which allows air to rush in between the two layers, the two membranes, and the air forces the two membranes apart. So you end up with a pocket of air in between the visceral pleura and the parietal pleura. And this constricts down on the lung, and it stops the lung from contracting properly, okay? Just to give you an idea of where the lung tissue is supposed to be, this line here shows you where the visceral and the parietal pleura are supposed to be. So this is where the lung margin is supposed to be, right? Normally the two membranes are so close, one sitting right on top of the other one, that there's really no space in between them, right? So this looks like one continuous layer. So normally it's more like this, okay? Now, once air gets in, remember what I said is gonna happen. Once the air gets in, it pushes the lung tissue down. Because of that, the lungs cannot properly inflate. And because the lungs can't properly inflate, when you try to breathe in, instead of the lungs being able to expand all the way out here, so the lung can only expand to the here. This, of course, now represents a collapsed lung, right? You can't breathe in very deeply anymore, which means you get less oxygen coming into your body. You're now in serious trouble, right? Now, a good way to get a pneumothorax is to fall off of a bike, right? Or to get punched in the ribs. If you break the ribs, you can push the rib, the broken end of the rib down onto the lung, because obviously the ribs are very close to the lung tissue. And this can just nick the membrane and pop a little hole in the parietal pleura membrane. And when you breathe out, you will suck air in from the chest cavity. It will go into the between the two layers. And now you have a pneumothorax, okay? You go to the hospital with this, the doctor will have to insert a tube into your chest cavity and into the pocket here to draw the air out in order to bring it back to normal, okay? Now, obviously, if both lungs have pneumothorax and it's a large pneumothorax, you can suffocate to death, right? All right. Any questions there? Awesome. Let's keep going then. All right, let's now talk about respiratory centers in the brain. I spoke about the DRG and the VRG already, but there are more respiratory centers besides just those, right? You have centers that control the depth and rate of breathing, all right? So let us talk more about these. I mentioned to you before that the respiratory centers are located in the pons and the medulla, right? And that the respiratory centers are, well, they basically are made up of 3 pairs of nuclei in the reticular formation of the medulla oblongata. You should remember the reticular formation from ANP1, and you should also remember that nuclei in the brain does not refer to a nucleus of a cell. It refers to a group of cells doing the same function. So in this case here, these 3 groups of cells are involved in controlling respiration, right? I mentioned the dorsal respiratory group already, and I mentioned the ventral respiratory group already, so I'm not going to mention them again, right? What I will mention, however, is the apneustic and the pneumotaxic centers, and those are in the pons. The apneustic center's job is to activate the DRG. Remember, the DRG is what triggers the contraction of the diaphragm and the external intercostal muscle, right? But it is the apneustic center that turns the DRG on. So this apneustic center stimulates the DRG, turns it on. The DRG turns on external intercostal muscles, turns on the diaphragm, you breathe in, right? When the apneustic center turns off, the DRG turns off as well, which of course means the diaphragm turns out, muscle relaxes, the external intercostal muscle relaxes, you breathe out, okay? That's normal breathing. So the apneustic center is important for that. Even doing forced breathing, the apneustic center is still the one that turns on the DRG. And since the DRG turns on the VRG, the apneustic center also controls the rate of your breathing. The more often the apneustic center turns on, the more often the DRG will contract. And if this is in forced breathing, the more often the VRG will contract, will send the muscle for contraction as well, right? So remember, apneustic center turns DRG on. DRG turns on the muscle, the external intercostal diaphragm. During forced breathing, DRG also turns on the VRG. Apneustic center turns off, DRG turns off. During normal breathing, you breathe out. During forced breathing, DRG turns off, VRG turns off, except for the muscles involved in forced expiration, right? The pneumotaxic centers now, on the other hand, these guys inhibit the apneustic center. The pneumotaxic center will allow the apneustic center to be turned on, or it will turn it off, right? So the apneustic center turns on the DRG, but the pneumotaxic center turns off the apneustic center. So pneumotaxic turns off apneustic, apneustic turns on DRG, DRG turns on VRG, right? Remember, at any point if you're not understanding, you can stop me and ask me, right?
Repeat what you just said about the apneustic.
So the pneumotaxic center turns off the apneustic center, right? The apneustic center turns on the DRG, and the DRG turns on the VRG. So if pneumotaxic center sends an impulse to the apneustic center, it shuts it down. And if the apneustic center shuts down, the DRG shuts down, the VRG shuts down, and you stop breathing. All right? Once the pneumotaxic center shuts off, the apneic center automatically turns back on. So if the pneumothorax center turns on and off 15 times per minute, it means you're breathing 15 times per minute. All right? So the pneumothorax center turns on the apneic, and that turns on the DRG so you can breathe. If you turn off the apneic center, you can breathe out, but you can't breathe in, right? All right, now let's talk about some factors that affect the rate of breathing. There must be a signal to the pneumothorax center telling it to turn itself on more often or off more often, right? And that is going to come from your senses. Now, your hypothalamus is extremely important where this is concerned, right? And there are basically 5 changes that your body is going to be sensitive to when it comes to the rate and depth of your breathing. One of them is PCO2, then you have PO2 or pH. Can I assume everybody understands what the P here refers to? All right, I hear no objections, so I'm assuming you know it means partial pressure. All right, cool. And of course, pH, how acidic or alkaline something is. You all know that one already, right? Now, baroreceptors in the aorta and in the carotid sinuses are going to be sensitive to changes in your blood pressure. So, your blood pressure changes picked up by the aorta or the carotid artery will affect your breathing rate. The concentration of carbon dioxide in the blood or oxygen in the blood or the pH of the blood will all affect breathing rate, okay? So all we need to know is explain how they affect the rate. I'm jumping around a little bit. Let's do this slide next. Give me 1 second here. I'm just changing the order of something here. It'll make it a little easier for you to understand. All right. Now it says here, now stretch receptors respond to change in lung volume, irritating physical chemical stimuli in the nasal cavity, larynx, or bronchial tree, right? So basically, if you breathe in a noxious chemical, it can change your breathing rate and depth. So if you've ever broken open a rotten egg and the rotten egg smell hits you, you breathe more shallowly, right? And more slowly initially, because you're trying to minimize your body taking in the rotten egg smell, because the rotten egg, of course, the smell of it contains poisonous gases. That is why you find yourself either holding your breath or breathing slowly and shallowly, right? Irritating physical stimuli. If you get sand in your nose or down into your lungs, you realize that your breathing rate changes as well, because the sand irritates the lining of the inside of your lungs or your trachea and will cause you to sneeze or breathe more shallowly as well. Pain. Pain changes the way you breathe. Pain tends to make you gasp in. So if, for example, normally if somebody gets stabbed or slapped in the face, the first thing that happens is that they tend to pull in air, they tend to breathe in deeply, right? So that sudden sensation of pain causes a change to your breathing rate. Changes the body temperature. The hotter you are, the faster you breathe. The colder you are, the slower you breathe, right? If you get hot, you breathe faster. If you get cold, you breathe slower. Abnormal visceral sensations. You can look at it in terms of gas. If you're very gassy, every time you tend to breathe in more shallowly, right? Because breathing in deeply when you have gas feels uncomfortable, right? So you tend to breathe in more shallowly. Then it mentions that the respiratory centers are strongly influenced by chemoreceptor input from the cranial nerves, cranial nerve number 9, which you would have done in AMP1, from the carotid body. And it is stimulated by blood pH or by oxygen, PO2, right? Cranial nerve 10 from the aortic body is stimulated by changes in blood pH again, or PO2, right? And it mentions you have receptors in the monitor that monitor cerebrospinal fluid and that are in the ventrolateral surface of the medulla oblongata that respond to CO2 levels as well as pH of the CSF. Here is how this goes. If you have low pH in the blood, if your blood is acidic, right? The glossopharyngeal nerve, the vagus nerve, will pick up that decrease in your blood pH. This, of course, means you tend to have more lactic acid in the blood, for example, right? Maybe you're running, and as you're running, you're building up lactic acid in the muscles. So these nerves pick up these changes, and then they send the information to the medulla oblongata, right? Sometimes via the hypothalamus. And this causes your breathing rate to increase. So that if your blood becomes more acidic, you breathe more quickly. If your blood becomes more alkaline, on the other hand, right? Let's say you hyperventilate, you breathe out a lot of carbon dioxide, right? So now you have more basic blood. Once again, the nerves are going to pick this up, send information, hypothalamus, medulla oblongata, and then it will cause your breathing rate to decrease, right? So if your blood becomes acidic because you're running up and down the place, once you stop running, you breathe heavily, right? Because you need the extra oxygen to break down the lactic acid. So your blood pH returns to normal. Once your blood pH returns to normal, your breathing rate slows back down, right? Remember, the cranial nerve 9 and 10 are picking up the changes to your blood pH, sending it to the hypothalamus, sending it to the medulla, right? Oxygen levels. If your blood oxygen is too low, once again, the nerves will pick it up, send it to the hypothalamus, causes your breathing rate to increase, right? Now, in terms of the cerebrospinal fluid, you hopefully understand that the CSF is going to be found around the brain and around the spinal cord. And the brain and the spinal cord are very, very sensitive, right, to oxygen levels, carbon dioxide levels, and pH. Well, carbon dioxide levels more than oxygen levels, right? Because of that, you have these receptors that monitor the condition of the CSF, right? If the PCO2, the carbon dioxide level in the blood is high, that carbon dioxide will make its way into the cerebrospinal fluid, right? Which makes it more acidic, which is bad for the brain, bad for the spinal cord. You do not want acidic fluid around your brain. So if this starts to happen, it triggers the medulla to cause you to increase your breathing rate. You breathe more heavily to get rid of the extra carbon dioxide, so your pH of your CSF will go back to normal, right? So carbon dioxide affects pH, and if pH drops, you breathe more heavily. If, of course, your pH gets too high, you breathe more slowly as well, because you also don't want too alkaline fluid around your brain and spinal cord either, right? Now, that said, is there anything here that you want me to review or that you're not sure about? That was a good time to ask. All right, next step. Let's talk about hypercapnia and hypocapnia and the result and what causes them. In hypercapnia, you have an increase in the amount of carbon dioxide in your blood. So as it says, arterial PCO2 increases during hypercapnia. And this, of course, stimulates the medulla oblongata, which will cause you to breathe more rapidly, okay? So high CO2 in the blood increases the rate of breathing, right? And you can also have something called, well, hypercapnia can be caused by hypoventilation. Of course, in hypoventilation, you're breathing more slowly than normal. And because you're breathing more slowly than normal, it gives carbon dioxide a chance to build up in your blood. And as carbon dioxide builds up in your blood, of course, the blood becomes more acidic and etc., which of course triggers the medulla to cause you to breathe more rapidly, right? But if you want to generate hypercapnia, either you hold your breath or you breathe slowly, right? But you can also generate something called hypocapnia, right? In hypocapnia, your carbon dioxide levels are lower than they should be. Remember, there's a set point for everything in your body. So there's a certain amount of carbon dioxide your body wants to be in your blood and in your tissues and in the other fluids, right? If it gets too low, it's a problem too. Even if it's a problem when it gets too high, right? So if you are hypocapnic, you do not have enough carbon dioxide in your blood, other fluids and tissue, right? You can generate hypocapnia in yourself by hyperventilating, right? Of course, hyperventilating, you breathe as fast as you can, and as deeply as you can. This clears out extra carbon dioxide from your blood, which leads to hypocapnia, right? Now, why would you want to be hypocapnic? There's actually a couple of reasons for it. We'll get to that in a second, right? Now, let's talk about the baroreceptor.
No, sir. Go back and explain hyperventilation one more time.
Hyperventilation. You're breathing as quickly and as deeply
No,
as...
sir, not that one. The one before it.
Hypoventilation?
Yes, sir.
You're breathing slowly. In hyperventilation, you're breathing much more slowly than normal. It's the opposite of hyperventilation. And because you're breathing slowly, it gives carbon dioxide a chance to build up in your blood, which is what leads to hypercapnia. So breathing slower than normal causes increased CO2, which is of course hypercapnia. Right? Hypocapnia, when you hyperventilate, you breathe faster than normal, you remove extra carbon dioxide from the blood, that gives you a hypocapnia, right? All right, baroreceptor. So the carotid and aortic sinuses have baroreceptors that affects blood pressure. When the blood pressure drops, you have an increase in your breathing rate, right? Blood pressure drops, your breathing increases. Your blood pressure increases, your breathing decreases. So it is the carotid and aortic receptors that will pick that up, right? Remember, blood pressure increases, your breathing rate decreases. Blood pressure decreases, your breathing rate increases. Now let's look at some protective reflexes, right? I mentioned to you already, sneezing, right? Sneezing, coughing, laryngeal spasms. When you breathe in noxious chemicals, right, it will result in the coughing, the sneezing, all of these things, right? But mechanical stimulation. If you stick your finger up your nose and start scratching around in there, right, which is something I don't advise you to do, you can trigger a sneeze reflex, right? That's what I mean by mechanical stimulation. Or if you stick a cotton swab up in your nose, right? For example, when they're doing the tests for coronavirus, they take this long cotton swab and stick in the nail up your nose, go all the way to the back of the nasal cavity and swab, right? One of the problems people will have is that they feel the urge to cough or sneeze because this long Q-tip basically is stuck all the way to the back of their nasal cavity. It is, of course, uncomfortable, right? Chemical irritants, if you've ever breathed in pepper spray, or what, I'm assuming not. But, smelling salts. The reason why smelling salts bring people back is because it irritates. And if you if you take a deep breath of smelling salts, it makes you want to cough, and you can feel a laryngeal spasm, right? So your larynx actually feels like it tighten up. Then now, I don't know how many of you know the term apnea. The most common type of apnea that you probably would have heard of would be sleep apnea. Basically, in apnea, you're breathing quite nicely, then you, for some reason or other, you simply stop breathing for an extended period of time. So long that your carbon dioxide levels start to climb so high that it forces you to cough and resume breathing, right? In sleep apnea, this happens, of course, while you're sleeping. Now, what normally happens is that if you snore, in particular, if you snore loudly, you're at greater risk of developing sleep apnea, right? I know women always say that they don't snore, but y'all do snore. That said, men are more likely to develop sleep apnea than women, right? So you'll be sleeping, then the soft palate, for example, might shift position and close off the airway. And when that happens, you can't take in a breath. So you stop breathing. And you'll just be there, and you'll be there. You're still out sleeping, right? And then once the carbon dioxide levels get hard enough, you're forced to cough. And the coughing will partially wake you up. Right? Then you start breathing again. And then you slide back into sleep. As a matter of fact, it will probably not wake you up enough that you are aware of what is going on, right? So you'll have sleep apnea. You'll be constantly being woken up by the sleep apnea, but not enough to bring you back to consciousness, but enough to interrupt your sleep cycle. So you'll get 8 hours of sleep, wake up the next morning, you feel terrible. You feel like you hadn't got any sleep at all. That's because you're constantly waking up during those 8 hours. So you never actually got 8 hours sleep. You got increments of 10 or 15 minutes sleep during the course of the 8 hours, which is not restful sleep, right? Now, this diagram here is going to summarize everything we just went through, right? So I leave it to you to review that when you have the time. Also, I want to make sure should do this. All right. Emotions. Believe it or not, emotions also have an impact on your breathing. As I mentioned to the class earlier today, anger. If you've ever seen anyone get really angry, get in a rage, you can see most people build up to the rage. You can see that their breathing rate starts to increase and start to breathe deeply and heavily, right? And when you see that happening, you know there's an explosion coming, right? Or depression. People who are depressed tend to have slower breathing rates than average. So extreme anger can cause your breathing rate to increase. Severe depression can cause your breathing rate to decrease, right? Then now, anticipation of strenuous exercise. If you are going to run a race and you know the race time is coming, you'll actually start breathing more heavily before the race begins. What you're doing is that you're pre-oxygenating your blood. You're adding extra oxygen, getting rid of extra carbon dioxide, so you can maintain yourself for longer, right? Also, you can have closing of airways due to emotions as well. People say that they're so angry they can hardly breathe. As an example, once again, emotion that can trigger, right? But if you're exposed, if you have allergies, it can also cause temporary closing of the airway. So you breathe in the allergen. Let's say you're allergic to pollen. You breathe in the pollen, and what happens is that your immune system, in its great intelligence, decides that the pollen is so dangerous that it has to save you from the pollen by narrowing your airways, right? Which makes it harder for air to get down into your lungs, which is, of course, results in the wheezing sound you hear people will have sometimes with pulmonary allergies, right? Now, remember, this slide here is going to give an overall impression of what we just looked at, and you can use this one to study it nice and easy. All right. And that is it for respiratory system. So the next time you see Miss Martin, she's going to start digestion. But before we do anything else, are there any questions anyone would like to ask? Cool. I guess that means all is well. All right. What I'll do is I'll post this in an hour or two, and I'll leave a link in the Zoom so you can get it if you want to review it, right? Unless there are any further questions, I'll end the class now. And good luck on next week's in-course test.